One.
At the item 11.2, we can defer to another meeting that will be optimal timing wise.
Okay, actually, with just having the in-camera minutes and, if it's all right with the board, we'll just dispense of having, any in-camera at all today, and, if we can just do those minutes and at the next meeting. There's no action from those or whatever, so if everyone's okay with that, we'll, let's say, just defer the in-camera till the next meeting then. I guess, oh, sorry, Mr. Roll Call first. Sorry, Kaylee.
Chair Beckett,
Present?
Sue Patterson, Kevin Nichols,
Present.
Helen Claire,
Good morning, everyone.
Chris Peabody,
Present.
Luke Charbonneau, and Brian Milne send their regrets. Kenneth Craig, Nick Saunders.
Okay, thanks, Kaylee. So I look for a mover to have the approval of the agenda. I'll have to go to full names to develop this. So moved by Sue Carlton, second by Sue Patterson. We approve the agenda as presented. All in favor? That's carried. Any disclosure of pecuniary interest from anyone? Seeing none. Next is the newly appointed board members. Having welcoming here. Good morning, Member Craig. Morning. Just got started, so with only one member here, Sue Carlton, here to take a few minutes and introduce yourself to the board, please.
So I'm Sue Carlton, Mayor of Georgian Bluffs and Grey County rep on this board with others. That's about it.
Welcome to. It's enjoyable. It's a great committee. Great members. You know, pretty diverse throughout Brandenburg County. So anyway, we look forward to you being on board here. Next, we move down to the adoption of the minutes of the meeting on Friday, March 31st. We have a mover of those to get them on the floor. Moved by Mr. Craig, second by Warden Peabody. Discussion, any discussion here? Seeing no discussion, I'll call for the vote and all in favor of those minutes. That's carried. Correspondence and news releases.
Thank you, Mr. Chair. So there are a few correspondence items. The first one is a letter from the Ministry of Health as a response to the board letter. The letter co-signed by our board and Saugeen First Nations. And the main aspects of the letter is affirmation from the Ministry of Health of the collaborative and supportive approach and acknowledgement of our suggestion to establish multi-sectorial task force. Just in terms of background about the letter, we sent a letter last year and we renewed the letter this year related to the opioid crisis, and we suggested 5 items, the most important of which was suggestion to establish task force provincially and having representation board. So there was acknowledgement there of the suggestion. There wasn't an action at this point. So that's the first item, and it is my recommendation to receive it. The second item is communication from the Executive Council of Ontario order the appointment of Mr. Nicholas Saunders as a representative provincially. The recommendation also to receive.
Okay, thank you. Can I have a mover then to accept those two pieces of correspondence? Moved by Member Eccles, second by Alan Clare. Any further discussion? All vote and all in favor, that's carried. Next is media release.
Thank you, and through you, Mr.
Hi,
Chair.
how are you?
Hey, good, thank you. There are 7 media releases on today's agenda. 2 relate to dog bites and request the public's help in finding the owners of the dogs involved. In addition, in late March, a media release was issued about public health's plan to begin in-school vision screenings for senior kindergarten students at Blue Water District School Board schools this spring. 2 releases, one on March 28th and the other issued April 4th, were sent out following clusters of drug overdoses in Grey Bruce. The releases warn about the toxicity of the unregulated drug supply and urge people who use drugs to practice harm reduction strategies. An April 14th media release reminded the public that with the arrival of spring, people should take steps while enjoying the outdoors to protect themselves, their loved ones, and pets from Lyme disease. And the best way to prevent Lyme disease and other tick-borne illnesses is to avoid being bitten by a tick. And finally, on April 20th, Public Health issued a media release marking to let the public know that we are marking Earth Day on April 22nd. One of Public Health's priorities is to educate the public about the physical and mental health impacts of climate change and collaborate with municipal, community, and other partners on climate action that protects the health and well-being of everyone. And that concludes the media releases.
Thanks, Denise. Could I have a mover to accept the media releases, please? Moved by Ken Craig, second by Warden Peabody. Questions? Mr. Craig?
Thank you for that report, but through you, Chair, more broadly speaking, the strategy regarding communication. I appreciate getting these, but is it I can confirm of the board to distribute these press releases to members of the local councils? Is the Kincardine Council broadly on that mailing list? I do not know the answer to that.
Good question. I don't know the answer to that. Dr. Era?
Through you, Mr. Chair, the subject, we send the media releases to the media outlets, to certain partners. But if the subject was of significance, I usually send the same media release to a distribution list of over 900 people, including councils.
Okay, so it through you, of course, it goes to our senior staff for distribution down through, or is it like are our council members personally on that distribution list? Do you not? I'm just encouraging that it is. I don't care whether they are or not. You don't have to tell me right now because you maybe don't know, but if that's a sort of strategy the more broadly spread, because it is they that are grass on the ground in our community to help spread those words, and it's just an encouragement on my part.
Certainly, Mr. Chair, my list has the head of council, the mayor of the warden, and the CEO and the clerks.
Okay.
But not the individual councillors. Obviously, if there is an issue that's related to the specific municipality, we can communicate and tailor any communication. If I can turn part of the question to Denny just for the technical part, just to be complete there. The distribution list, Denny, that you sent to, if you can elaborate on it.
Yeah, so the list includes all media outlets in Grey Bruce, and there's also partners. So the main partners would be like Bruce and Grey counties, and also Grey Bruce Health Services would be one as well.
I can just elaborate. For example, the dog bite ones, would that go to municipality Beaver? Or not then? On a normal basis, I guess going back to Ken's question here, if it was to a specific municipality, then would it go to them?
Denny, like I don't, Mr. Chair, I don't echo the dog bite just because there's around 400 a year. So you don't want to over saturate the messaging aspect, but Denny, if there was any specific communication to the municipalities or just the media on that one?
So For each media release, they are also sent to the program managers who would distribute them based on local needs. So for example, the ones about overdoses, for example, there's quite a list of partners and organizations that would receive those media releases from the program managers. So from it wouldn't be from communication specifically, but it would be from the program managers.
That answer your question, Ken?
There's an excellent strategy in place. I appreciate your comment about oversaturation too. That's not an issue that you generally worry about, but from your perspective, you know, if after a while you get tone deaf to the message. So that's well thought out. Thank you.
Okay, so we get a mover and seconder then on the media releases. Any further discussion then on that? Okay, call the vote, then all in favor? That's carried. Next, we're on to Medical Officer of Health update. Dr. Aaron?
Thank you, Mr. Chair. The update on COVID-19 is very similar to the last update, and if we have a similar positive one next month, it would be my approach to remove it as a standing item. So there has been a stable number of new cases, quite manageable, very manageable. Hospitalization, the number of outbreaks right now in long-term care is 0. There are 2 outbreaks in community settings, community setting or retirement homes, which is quite reassuring that the circulation is manageable. And we look at if you take a look at the outbreak list, COVID is 2 out of 6 or 7, so more or less it will be normal business as we proceed to breaks as needed. Open to questions as always.
Okay. Any questions for Dr. Aaron? On to Ken.
Sorry. I'm not sorry. I mean, that's
What we're here for.
through you, Chair. South Bruce Grey Health Centers issued an encouraging report the other day in that they have relaxed some of the mask requirements at the 4 sites in the still pertains to emergency waiting, treatment, and inpatient rooms. So supposed to wear. My question there was, for a regular patient, what does that mean? There's no difference. Administratively, if you're in the administration side, big difference. But has there been any changes that parallel that through Grey Bruce Public Health? Like, has there been any changes to your instructions regarding mask usage or not? Or where I think we were a little more proactive than the hospitals in relaxing that. Can you comment on that just a little bit for me, please?
For you, Mr. Chair, yes, most definitely everything you said is correct. We are least intrusive. We designed the intervention to manage the risk with the principle of least intrusive, and we had relaxed the requirement for masks way
Some time ago.
less than I would say most of the organization out there. One, our building is administrative in nature. We see patients in the clinics, and that has a different aspect. And number 2, we have the ability to ensure a safe workplace for our employees through the space that we have and the different interventions, cleaning and separation. And obviously our staff are the expert in this issue. So there has not been any significant issue related to transmission that is concerning. And if I can take this question and generalize it as well, throughout the pandemic, if you look throughout the province, there has been a number of orders and letters of instructions from MOHs to businesses, to schools, to many organizations. To my knowledge, we have the least intrusive approach throughout. There has been 2 orders, class orders, one for mask until the province came in with their mask, and there was another one related to people who don't abide by the isolation, which was very minimal throughout the first year, got increased over the second year, which is expected in pandemics. have the tolerance to these interventions takes place. And, throughout, relative to other parts of the province, we have been in the green, and throughout we have had less intrusiveness to our businesses and to our operations in general in Great Bruce.
Okay, move on then to next point. 8.2, the opioid. Dr. Zed?
Mr. Chair, in light of the increased, the cluster that happened, I would like just to discuss what was that and the interpretation of this incident, and in the same time, showing what has been updated for many details that happened the last months. So as you heard from the press release, can you go to the next slide? Yeah, so that we had overdose early warning system report, 18 reported overdose reported from March 27 to April 3rd, 15 people were male and 5 females. The age of individuals involved in the reported overdoses ranged from 19 to 68 years, and the average age was 38. There are some like this cluster is considered alarming. We need to, as public health, we needed to analyze the situation and have an immediate situation assessment. There are some variability in terms of age. So we have seen older age and younger age compared to the normal. In addition to that, we also connected with other health units, and they have seen a similar cluster, especially in Toronto and big health units. So that was not like, it was not like we first found that it's what we are not only the only one, only health unit who have this issue. So there must be something around the drug, the illicit drug landscape. So the immediate action that we had with that is that that prompted some action. We worked with our collaborators from EMS, police, SOS, to map areas of increase of opioid use activity in certain area across the Great Bruce. The other things, we enhanced surveillance through local collaborators and provincial partners on drug checking and the changing landscape. So we tried to see what is going on. We reached out to drug checking services in Toronto to see what kind of changes that they have encountered. There was no like more potent drugs than the usual, but maybe people are using more or using more potent, adding benzodiazepines to the mix that they are using, which increase the dependence and increase the overdosing, like the exposure for high overdose. Enhanced surveillance also through collaborators and enhancing accessibility to harm reduction tools. For example, we distributed naloxone. There is some eligibility to have naloxone in certain centers. We really bypass this eligibility and have naloxone distributed in every place we find that there is increased consumption. So with the enhanced knowledge that we have, we increased the naloxone distribution, not only on eligibility of organization, but based on increased consumption activity that we found. The other thing, we developed more strategy to reach out for people who are using drugs or who have experienced this sort of overexposure. So before, like we know the mechanism, what happens, there is someone who experiences overexposure, and and then he or she gets naloxone, and after that they recover, and either they recover in the hospital or they recover in their place. So we wanted to know more about this population who experiences overdoses. What are the circumstances? So the most important thing is to have these post-event details. So we developed a form. The form has no identifiers, but it helps us to understand. So the EMS or the hospital emergency department or physician who is working or healthcare provider in the hospital would fill this form and fax it to us. So that would be a more intense trying to reach out with our communication and messages to people who are experiencing overdose. We find also that people do not know what they are using. So that's an important part. People who are connected to outreach service, we find that during the last year with SOS, they have never had any overexposure overdose event. So having that, so it's just 100%. And 6 of them actually now are like, we don't ask people from the harm reduction perspective to stop what they are doing or using, but some of them really, like around 6 people have now become drug, like discontinue the drug. So which is a good thing, but we are supporting people who use drug. We are supporting them through SOS for mental health, for counseling, and other non-health services, including obtaining a health card, getting a house, getting a job, coping skills. So we find the experience is very good. People who are using and experience overdose, we find that their information about SOS is limited or they are declining. So we are trying to reach them through the fixed sites by offering like foods or events so that they gain the trust and then they try to connect. So we are now targeting more connection for that. We develop more strategies for that with the working with SOS. And also the other things that we added with this action is to connect with drug checking services in Toronto. They have 5 sites, 5 related to their consumption, safe consumption sites. They are very helpful. This is free of charge, but we try to find a process to maybe send some of the used equipment or drug remains so that we will be on top of what is consumed. There is another service also through courier to BC for that service. So we are trying to use this service and really advocate to get this drug checking services in municipalities, not only in Toronto. Next. Yeah, so now I'm just, other than this situation, I just want to show where we are at from last year, for example. So I'm taking this suspected drug-related monthly from coroner. This is for Grey Bruce, and we see March 2022 in compared to Ontario. So we are in a plateau in that part, but it's not like much increased like if we compare to the lower curve. When you see in Ontario, the curve is going up. So also the data, as I mentioned before, is always power. To know where we are at. So compared to the province, we are doing good. There are increase in some part here in 2022. And if we go to the next slide, So that's, this is 2023, compared to the province. And so that's in March 2023. So there is really a good downward decrease in suspected drug death. So that's also a good indicator. We should always stay positive and do whatever we can, utilizing multiple strategies. Next slide. This shows monthly emergency department visit. So you can see here in 2022, Grey Goose is a minimal for across the health unit in terms of the emergency department visit. And I would say that this is a good sign, because we are optimally using the service, and the outreach services really start to get to kick off and have some support in the community, and that's what we want. We don't want people to go to emergency. The other thing here in 2023, it's even like better. We still have our the level of our emergency department visit is in good shape. Next slide is, this is a slide that I used before about the Grey Goose opioid and drug toxicity data, and now I added some the 2023 data. So in 2018, we had EMS calls of 74 and the 77 confirmed related death. And I just started from 2018, just prior to the COVID. In 2019, we had increased EMS calls and the suspected drug-related deaths are 23 and confirmed drug-related deaths is 17. And then we have in 2020, which is the peak year of COVID, where we had much increased death and increase in EMS call and emergency department visits. In 2021, that also is during COVID, and we had increased number of deaths, increased number of ED visits, and 140. When we started in October 2021, the SOS service after the Hanover outbreak, we started to see good results. So EMS calls were 123, and we start to have less ED visits, and the suspected death, drug-related death is 34, and we can see the confirmed drug-related death is 19, which is really good number compared to the previous years. So we are, I don't say like mortality is drastic, even for one, but I mean for population indicators, we are doing much better. In 2023, the EMS call was 43, the ED visit was 11, and it is one of the least visits across the province. We have suspected related deaths as 4 for now, nothing still confirmed by the coroner. So we are trying all the activities, the added post-event and the added drug checking services. I hope that it will make an effect to connect with people who experience overdose. The next slide is about a summary of what we are doing right now as public health intervention. So foundational standard team is doing a situation assessment report in public health about what's happening, including even what is the public perception about this. So even communication is included or sharing their part in this situation report. The enhanced surveillance, as I mentioned, is something very important. The naloxone distribution that we are expanding other than areas that are that are like organizations. So it's expanded to over those areas, post-event connection and drug checking service. The other thing that also is just I want to maybe give more light about the drug checking service, that it started in February 2018 in Toronto as a pilot design. And in 2019 to March 2023, they finished the plan for expansion and finished their pilot project. And there is more now building advocacy for expansion and removing barriers to checking service provision. It reported a semi-quantified results. It is highly sensitive and fast. It shows fentanyl-related drugs, fentanyl-related synthetic opioid, benzodiazepine, synthetic cannabinoids, and other drugs like levamisole, phenacetin, and xylazine. The effect of these high potent drugs, according to the situational report that we have, it meets the needs of increased tolerance. So when people mix with diazepine, they have high dependence, so they use more. To give, some people say to give it legs, so it prolonged or enhanced the desired effect. And a real outcome that we focus on in communication right now, that this kind of mixing or using high potency will lead to extreme prolonged sedation and dangerous suppression of respiratory system, more naloxone required to reverse the overdose. And it also lead to increase the risk of vital suppression. It has high potential of dependency. And with xylazine, for example, there is more skin ulcers and this kind of skin effect. Some of the service of SOS also are using are also supporting with treatment and all these kind of things, and more education on the overdose and the potency of drugs. So that's what we are trying to do. The most recent thing also last week, that Chief Coroner agrees about our request to provide a toxicology report either every quarter or every month, but we received the first report, and I think over time it will be helpful as well. So that's my update. Thank you.
Okay, thanks, Dante. That's very detailed, and
Sorry for that.
strong. No, it's, okay,
Lots of more activity actually.
that's a reality check that's going on in there. Dr. Eric.
Thank you, Mr. Chair. If I can just go back to the slide, if I can share my screen, Kaylee, I just want to echo what Dr. Zayed said on 2 points, possible. I can't share my screen. No, I have to be a presenter.
Oh, I can check that right now.
Okay, thank you. Thank you.
We should be an administrator, Kaylee.
So just to echo what Dr. Zayed said, and to answer a few of the questions that were asked last meeting about the numbers, there was a question, are we seeing an increase in overdose? Because we're hearing more about it in our media releases, and the answer is no. Actually, the number of overdose this year is similar to last year. I think it was 14 last year this time.
12 last year, 14 this year. So there is, and as you see in the curve, that we are plateauing in that area.
So there is no difference between 14 and 12. Whenever you look at percentage, you need to go over 20 or 30 to generate a ratio. The only difference is our focus to actually identify and raise awareness. So there is an artifact increase from our communication. The number of deaths, and this is, if you look at the screen there, I'll point out to the numbers I'm talking about. There were 40 in 21, and 19. This is a decrease by 50%. This is way more than would any medical officer of health would dream of. Usually, if you look historically, tobacco strategies, reduction by 7% per year is really good. So we were aiming, if we can, I don't think we're going to be able to do the 50% again and again every year, but if we aim for 15, that would be a good, reasonable outcome or a reasonable goal. You look at some of these numbers, you can infer a few things from. There is an increase in the number of EMS calls, but there isn't as much increase. There is actually a decrease in the ER visit, the emergency department visit. And this is what Dr. Zayed pointed out, and this is the word stigma. All the strategy about the stigma, you can see that there is a positive effect of it, where people are comfortable calling the ambulance to mitigate the issue, address the issue at home, instead of leaving the person to end up in the emergency department, or unfortunately, some people will end up in the last column, which is the death call. So again, we talk about the stigma and the intervention for it, and you can see from the number, there is a positive effect of this work. And throughout the community, not just our work, we work with partners and different organizations. You look at the number of EMS calls, 43, and we're around 4 months in the year. So and the number of deaths, it's very similar to last year. And this is, again, not an increase, but to me, is not good enough. We need to see a decrease. Like, if we're not seeing the decrease, our interventions need to be altered. Again, a few of these points there. And there was another question, I'll go to this slide, about where we sit in the province. You look at the problem in Toronto, the last line down there, and this is adjusted by population. So regardless of the size of the health unit, it's adjusted to it.
It's per 100,000 or something like that. Is it
Something like that. Yes.
Okay.
So you'd look at in March, it happened to be, we were the lowest. If you look at the rest of the months in 2022, we were not the lowest, but we were in the lower spots between 1 and 5. But if you see the difference between the number of ER visits in Grey Bruce and Toronto, it's the scale of magnitude. Like, this is more than 20 times. So again, we do have an issue, and I have an issue that any preventable death is a tragedy. It affects obviously the person, the family, the community. We have close-knit communities. So if there is one death, it affects the whole town. So again, one death is too much, and we need to work on that. But you look at the bigger picture of the population level, our interventions are on the right track to reduce this. And I have no doubt in my mind there are going to be more challenges. Anytime we figure out naloxone for opiate, you find 10 more designer drugs that naloxone doesn't work. And anytime you find a strategy to fix something, the drug industry mixes, or you are going to have many challenges, but with the team that Dr. Zayed is leading her efforts, I cannot thank her enough. Thank you, Mr. Chair.
Good. Questions from board members? At this time, I'd like to tell our board members as well. I think I've got I'll just finish this and I'll go clear. Rogers TV did a program taped a week ago with Dr. Zayed and myself, and I was just along to fill the screen. But anyway, and it was to talk about the opioid situation, and they did a phenomenal job on that. So it's going to be aired on Rogers TV May 7th, my understanding. So if you get a chance and can go on for Rogers to watch that program, I think they did an excellent job there of explaining, their roles in public health as far as what they're doing on that. So I would encourage everyone to view that when it is aired. Helen Clare, you had a question?
Yes, thank you, Mr. Chair.
Comment?
First, can you hear me? First, excellent
Yep.
presentation. Thank you. And I just wanted to point out a couple of things with regard to the stats. There is a delay, sometimes 6 months or more, in reporting these stats from the coroner. And so for where we are in the year, I think it's important to bear that in mind. And even some of the reporting for last year locally and provincially may not be fulsome even at this point. And the second thing is we need to stay aware that to look at the suspected and the confirmed drug-related deaths together, because I'm also aware that the coroner, because of the challenges of determining a cause of death totally to do with opioids, sometimes the determination is more cautious and so sits in the suspected rather than the confirmed. So I just wanted to say that because then the numbers look a little different. 2021, if you put those together, looks more like, 85, 86. 2022 looks more like 54. So I just wanted to make those points. And as it is for the local, so it is for the province with regard to those delays in the stats and also the number of deaths that could sit in suspected rather than confirmed. Thank you, Mr. Chair.
Thanks, Helen Claire. Are there any other comments? Sue Carlson.
Question, maybe Kevin and Sue can answer this. Is this SOS not what we were talking about yesterday at the county, and the county was supporting, asking the province to continue on with that funding, that they've actually stopped funding for it?
Stop the funding for emergency visits for homeless people that do not have a health card or an address, so they can apply for it.
Right.
So SOS is in supportive outreach service. SOS is in home sound and in.
Yeah, that answer your question?
Yeah, I think so, yeah.
Good. Okay. Any other comments then regarding Dr. Zaid's presentation? Okay, thank you. Then we move on to staff presentation regarding emergency management. This is Andrews. Good morning, sir.
Good morning. Thank you, Mr. Chair. Haley, can you also make me a presenter so I can share my slides, or?
Should be able to now.
Does Helen Claire have another question?
I think her hand is just still raised from.
So let us see how.
Yeah.
Oh. There,
Yeah.
okay.
She's back on.
Can you see my slides okay?
Yeah.
Okay, perfect. Yeah, so I'm, for those that don't know me, Andrew Bunt, I'm Senior Public Health Manager with Grey Bruce Health Unit, Grey Bruce Public Health, sorry. So as well as the sort of more strategic side of the senior management, I also manage the environmental health program, so safe food, water, healthy environments, tobacco enforcement as well. But from today's point of view, I am, as of February, I'm looking after the emergency management foundational standard. So today's presentation, I'll just briefly go over the standards and guidelines, a bit of a look at the process that we use at the health unit, go through the emergency response plan and some of the components of that. And then I'll end up with what the goals are for 2023, recognizing that we are sort of recovering from the pandemic. So in the Ontario Public Health Standards, emergency management for the last few years has sat at a foundational standards level. I think that's a good thing. It's reflective of the fact that it's important across all of the programs for the health unit. The foundational standards articulate specific requirements, and those requirements underlie and support really all of those program standards. And the goal is to enable consistent and effective management of emergency situations. So those, of course, are quite broad. Some of them would be similar to what you might focus on at the municipal level, such as extreme weather events. Others, perhaps a little bit more specific, obviously the pandemic being a very good example of that. Board of Health has certain requirements, and essentially it's to effectively prepare for emergencies, to ensure that 24/7 response and have a integrated and effective response across the health unit. So underneath the standards themselves are guidelines. We have a guideline for emergency management, and that is a document that's a little bit more topic specific. It gives us direction on actually how we approach the requirements. In this case, it requires that we develop our own emergency management program that must complement the municipal, provincial, and health sector emergency management program. So it recognizes that it doesn't sit in isolation. And again, it's making sure that thought process is essentially sort of extended through all of our programs during development and implementation. So we have communications both internally and externally. Externally, partners are communicated, of course, through our MOH, physician consultant, through program managers, and also for the lower tiers, specifically through our public health inspectors who may attend planning meetings or exercises, that type of thing. The whole process there really is designed to ensure that the public health emergency management program complements the municipal, but upper and lower tier, which not only is in accordance with the standard, but is also a kind of common sense thing to do, I think. Internally, we have an emergency management working group that basically is just make sure that we have representation for managers across the different programs. And of course, we need that to make sure that it is integrated into our organizational planning. So our emergency response plan, anyone who's involved with a municipality, or even in fact a lot of large private industry will have perhaps dealt with a similar plan to this. It's a coordinating document. Ours has for a number of years been an all hazards plan. So it contains information on the different types of emergencies that we might see at a high level. And it has quite a bit of information on the IMS structures. That's the incident management structure, essentially the way that we organize ourselves and manage the public health during an emergency. And then it also links to related plans and appendices. So the HIRA, that's the Hazard Identification Risk Assessment document, and also our Continuity of Operations plan. So a little bit more detail on IMS. IMS has been around for a few years now, really started with fire response, where it was realized that there was a lot of advantage in having common language, common structure, and even actually in their case right the way down to structure and infrastructure that works together for when interoperational requirements. So that has spread to most sectors, I think, now. So we have the incident command that's actually supported by communications and safety officers as well. And then the actual response components broken down into operations, planning, logistics, and finance administration. Depending on the complexity of the issue, operations in particular can be broken down to have multiple people as well. In fact, one of the strengths of IMS is that it really is scalable both up and down. So for us, often it may be that an emergency, first notification of emergency starts with our 24/7 response process. Fairly quickly, once it's recognized that a situation is somewhat larger than one person can handle, we may expand through the fan-out process and have additional people. At the beginning of an emergency, we may not necessarily have an individual person for each of these aspects. But of course, the pandemic was an example of an emergency that went on for much longer. And in that case, we may well have not only one person, but perhaps multiple people supporting each section. So again, a little bit more detail of the top there with the safety, communication, and liaison supporting the incident manager. And again, that may not be the case immediately or for a smaller situation, but obviously, again, the bigger, more complex, the longer an emergency goes on for, the more support is required. So going back to our HIRA, our hazard identification risk assessment uses multiple sources to help us build what hopefully is a fairly accurate sense of what the risks are in Grey and Bruce. We lean fairly heavily on the county HIRAs to start off with. And then obviously, because our role is slightly different, we do also use other sources through the ministry, through Health Canada, and to some extent through our local staff knowledge of the area as well. We identify through that different hazards, and then we look at those hazards from the point of view of the impact on public health, as well as things like infrastructure and so on that the municipalities would look at to assess where we rank them in risk. And our risk level may sometimes be slightly different from the counties or municipalities, again, given that we have a slightly different role in dealing with those emergencies. We then will undertake an annual review to take a look, make sure it's still current, or if it's not, adjust as necessary. Then we have our continuity of operations. This is essentially the same as the business continuity plan. It identifies essential services to the public, identifies what sort of impacts there might be, and address those at different scales. It identifies critical infrastructure, because obviously, in our case, perhaps things like our IT services may be critical infrastructure for us to maintain. And in that regard, it really should be read in combination with the IT disaster recovery plan, which is a separate document that focuses solely on the IT side of things. Other relevant plans, well, again, right from the beginning, the intent of this is it doesn't sit in isolation. So obviously Ontario Health Pandemic Influenza Plan, disease-specific protocols, incident-specific regulations, and so on. In our case, perhaps the Provincial Emergency Response Plan. All these things are important and are sort of linked to. We don't need to recreate the wheel in each case, but we do need to make sure that our plan integrates with those different ones. So as we sort of transition somewhat away from the pandemic, obviously during that period 20 to 22, the focus of the organization was really on emergency response. We were dealing with the pandemic. So as we come out of that this year, we need to sort of phase back to that pre-pandemic, or some people call it an inter-pandemic period. Having taken the rollover in February, I have had a look at the documents and where we are. We're in quite good shape, actually. We do need to reestablish the regular workgroup meetings and do the typical things. So conduct the annual HIRA assessment. It looks pretty good, but obviously that's something that we need to do. Again, need to assess the emergency response plan itself. Again, I think it's in pretty good shape, but there may be some lessons learned over the last 2 years that lead to some changes. And then, of course, continue ongoing support and liaison with the county and municipal emergency planning processes. And I have just recently linked to Bruce Power as well, just to sort of I guess reinvigorate that partnership, because it's obviously they've a partner that we've worked with quite a bit in the past on this portfolio. And that is my overview, really. So I think at this point I can open up to any questions.
Good. Thanks very much, Andrew. Questions, comments from the board? Can't see our guests or our board members that are on via the screen.
No questions.
Any questions from
No
them?
questions there.
No questions there. Okay. Chris's hand up, or Warden Peabody's hand up? No, okay, sorry. I just was hard to tell there. Okay, well, there's no questions. Andrew, thank you very much for the report. The good news is, looks like we've kind of turned the corner, obviously, and focusing away from the pandemic responsibilities and kind of back to normal on their business that the health unit does. So thanks very much, Andrew, for that presentation. Mr. Greg.
So I'm sorry that I missed the approval of the agenda. We expect a traffic jam in Green Mountain. Car accident. Anyway, I have a couple of questions that are unrelated really, but I'm wondering, I don't know the right time to ask for their consideration either on this agenda or next month. And I just need your guidance about.
Something that's urgent that needs to get dealt with? Sure, probably we just put them on the next.
And how do I communicate that with you or through Kaylee?
Yeah, you can send it to me and then we'll have the discussion.
Okay, excellent, thank you.
Okay. Yeah, and thanks very much, Andrew, for your presentation. So if I could get a mover then to receive the medical officer's health update, which includes the three documents that were there then, Dr. Zay's report, Andrew's presentation and Dr. Eric's update. So moved by Sue Patterson, second by, I think Helen Clare's been on motion yet. So we'll have seconded by Helen Clare. Any further discussion then on the, accept those reports? All in favor? That's carried. Next we have Kim. Welcome, Kim.
Good morning, everyone. So through you, Mr. Chair, this is the February 2023 financial update. At the end of February, we were in a surplus position of 128,000. 34,000 of that related to our Healthy Babies and COHI program, which are programs that operate on a April to March basis. So some of that surplus has been brought forward from 2022 to be utilized in the first few months of 2023. And we've been able to utilize those funds before their year ends. And the remaining surplus was in our mandatory programs, which was primarily in our operating lines like materials and supplies and travel. Year to date, our funding is below budget as we just submitted our budget request to the ministry in April. So we're still waiting to hear back from the ministry as to what the allocations and approvals will be for 2023. And that's similar to the COVID funding. We haven't heard any confirmation on the request that we've sent in for the extraordinary funding for 2023 yet. Year to date, our salaries and benefits are in line with budget. So we have a small variance of 14,000 there. Our building and occupancy costs are also in line with our budget. And so it's mostly our operating expense lines that are under budget and notably in the materials and supplies, as I mentioned earlier. And that's pretty typical for our organization, as a lot of our programs do a lot of year-end spending in November and December. So there's not a lot of spending that happens in January, February at the start of our new year. For the Walkerton Dental Clinic, so we're currently in the design phase. So our team's been meeting weekly with the architect to finalize the drawings of the space. And then those drawings will go into a request for tender package. So then we'll formally take that out to market for bids and proposals on the project. And then we'll award a contract to a contractor who will complete the construction of the new space for us. And that's all I have for the report. Thanks.
Oh, okay. Thanks, Kim. Question for Kim regarding seeing none, we'll look for a mover and seconder to receive Kim's financial report. Put by Sue Carlton and by Warden Peabody. Any further discussion? Warden Peabody? No question, just, okay. Okay, I'll call on it's carried. To other business, Dr. Eric, the annual report.
Thank you, Mr. Chair. So the draft of the annual report here, it's worth mentioning there are a few things might be tweaked. It outlines health units work during the pandemic over the past 2 or 3 years. And some highlights of it is the vaccine efforts and the outbreak management efforts. And if you look at the other programs that are not related to the emergency, our health unit is one of the highest levels of commitment to completing these indicators or the other programs to keep them going while the emergency was going, and again, they're related to dental and healthy baby, healthy children, oral health, school health, and the other clinics that we run. Communication also has a page there. I'll stop there, Mr. Chair, and if there are any questions, I'm gonna have to address.
Okay, any comments? That's a pretty detailed report. I guess just from my perspective, or right near the start of the COVID-19 timeline, that's a really detailed sheet of that whole entire page on page number 5 shows a lot of detail there on how the sequence of everything has gone through. So I think that's a key one for everyone to look at and see what they think. The other in the report on on the page with oral health, the section that says Grey Bruce Public Health was the only Ontario public health unit to complete 100% of its in-school dental screenings in 21-22. I think is something very well worth noting, and the fact that they're still able to do that with everything else that was going on. I don't know if you wanted to comment on that, Dr. Hare, or...
Yeah, definitely. That's one example of where the direction from the Ministry of Health is to focus on emergency, and we had the option to put certain programs on hold or downsize them, and we had to do that with the section of restaurants. It was impossible because the sector was closed during certain times. Vaccines in schools was also paused. Nevertheless, any other program that we were able to focus on or to continue, we did our best to deliver.
Okay, and the other segment that I think worth noting is under communications with the logo change. I've heard nothing but positive comments on that. I'm not sure if anyone else has heard anything, but these are just things that have happened, obviously, since the last reading report went out. So, any questions or comments from any board members?
Thank you. I just want to say it's an excellent report, a lot of good information in this report. It's easy to read. The actual presentation of it is very good.
Okay. Any other questions or comments? Okay, not seeing anything, Dr. Hare, then we'll move on to the forward orientation package.
Yes, thank you, Mr. Chair, for you. The package is a document not to be read in one day, or rather, it would be optimal if the board members would reflect on it or review it. According to policy, we have designed a number of sessions, at least 2 sessions. Each one of them is 2 hours, where we had recording from the Alpha lawyer of a presentation that's very useful about the policies and the acts that are related to public health, Health Protection Prevention Act and the Municipal Act, and they will complement each other. These 2 approaches: the orientation package itself and the presentations. For example, our policies, how to approach the previous question from how to bring an item forward, if it is related to governance or related to operations, or that will go to the admin, and Kaylee will send it to both the chair and myself. But with operations, I would recommend to the chair to put it at a certain time, present a certain aspect. If it's governance, the chair would look at that. If you look at the policies and procedures, and in the table of contents it's mentioned there, it's in the package. The renewal of policies, the process of policies. If any board member identified any issue with any policy, what's the mechanism to bring it again through the same channel to that, defer it to the executive committee. The executive committee will put a recommendation to the board, and the board will decide on amendment of the policies. And so there are certain mechanisms that makes the operation way smoother, makes the work between governance and operation more effective. And like to me, some of these details are very interesting. Some people will read the act and fall asleep halfway. I actually enjoy the Health Promotion Protection Act. It's a very readable act. Again, we'll have sessions to discuss different things too. If people are did not cover it all in one week or so, but I'll leave it in your capable hand, Mr. Chair, to complete whatever's required to that.
Thanks, Dr. Just for the new members, the executive committee did review all the policies in 2021. And there is a policy on renewal. So they are up for renewal again then in 2023. So that will happen then throughout the course of this year. But to Dr. Harris' point, the board orientation, that is all then part of it to go through that as well. So hopefully that helps to clarify, how the internal operations are, let's say, of the board. And then of course, everyone has to sign off on having done the board orientation. And I gotta say, when we went through those policies, when Sue Patterson was Sharon, Helen, Claire, and myself, we spent a lot of time and a lot of detail going through some of those had not been reviewed for a number of years. And anyway, it was the directive of the board that we go through and update those, which I'm pretty satisfied that when the board accepted those back in whenever it was at the end of 2021, that we had brought things up to the standard of today. Well, regarding the process moving forward on that. So I think to Dr.'s point, there will be dates that will be scheduled then for the board orientation to go through Mr. Lenori's comments and before Alpha. That's will be part of the orientation package going forward. Mr. Greg.
Supplementary to our board meetings or included within one of the board meetings?
No, they'll be supplementary.
Okay, thank you.
We kind of want to focus strictly on that issue versus doing it this way, so.
Mr. Chair, Kaylee will circulate a list of dates and whatever works best for the majority.
Okay, we should have a mover to receive the last two presentations that were done by Dr. Hare under other business, the annual report and the board orientation package. Could I have a mover to receive those, please? Mr. Craig, seconded by Helen Claire. And this is making sure everybody gets associated with something during this meeting. So any further discussion then on receiving those two documents? All the vote and all in favor, that's carried. And as we mentioned earlier in the meeting, the in-camera does not need to be dealt with today. So we've put that off then until the next meeting. There was no update really for that. It was only going to be the minutes. So no use going in camera just to do the minutes. So we'll do those at a subsequent meeting coming up then. So I need one more motion. Motion to adjourn. Moved by one of the newest members, Steve Carlton, that we adjourn. All in favor? That's carried. Thanks, everyone. And we'll see. Mr. Peabody, did you?
No, I'm just going to say goodbye to everybody.
Yep. Okay. So we'll look forward to hearing from Kaylee regarding dates. Then we'll maybe be able to start that board orientation.
Okay.
Okay. Thanks, everyone. Have a good day.
Bye. Have a good day. Good weekend. Bye.